Hello.
Sir, you are visible, sir. Visible and audible.
But I
Technically.
No, wait. I am not.
I'm visible now.
Huh?
Right now, not visible.
So what?
Yes, you are visible, but your camera is facing up.
Facing up. No, something I think not great. I will log in again. Okay.
Yes, you are
Pavitra,
fine,
are you getting me? Pavitra, are you getting me?
हाँ sir.
You are getting me? I am. हाँ?
Sir, अपना कैमरा टिके डाउन करूँ तो अपना रूफ देखा जाओ टिके कैमरा डाउन करूँ तो. Yes, it's okay. Feroz sir is also fine. He is visible. Your screen is also visible. You are fine.
Oh, hello, Dr. Feroz.
Hello, sir. Good evening. How are you, sir?
Fine. After a long time we are meeting. Hello.
Yes.
So you are working in Mohana Orthotics. Prosthetics.
Yes.
Yes, that is Krishnan.
Krishnan.
I know. He is very close friend of mine.
Yes. He is close to everybody.
You must tell him.
Okay.
Tell him that I was remembering him. I stayed in his house for 2-3 days. Long back.
Yes.
When I was in Nirtar.
Okay.
Anyway, thank you very much for coming to this over here.
Pleasure.
Thank you.
So can we start, sir? Because recording is already started.
Oh, yes. We can start. No problem. Are we visible and audible?
Yes. Good evening, everybody.
And sensible?
Hello.
Yes, please.
Good evening, everyone. Welcome you all to this weekend PG academic webinar. In between last week we had puja, and last to last also because of midterm CME we did not conducted that weekend's webinar. From this week onwards again it will continue. Thanks to Dr. Feroz Khan for giving his consent for a beautiful talk on this how he is managing single-handedly pain and posture problems in his clinic. So as you all know that this rehabilitation is a teamwork. It normally involves multiple discipline, other paramedics also. Many times when we get a patient, normally we sometimes we refer the patient to other paramedics or other departments for help. But so long as we are working in a hospital or in a institute or in a college, the hand of senior is on your head. So most of the time, your senior is answerable whatever treatments you are doing. But when you come to your practice, when you will come to your clinic, when you will have to handle the patient single-handedly, that time you are answerable to the patient's question. Whatever you have done, you are answerable to the patient. So that means you must know how to handle single-handedly in your clinic for managing different types of conditions. So I hope the talk of Dr. Feroz Khan will be very interesting, that how he's managing his patients in his clinic. Dr. Feroz Khan do not need any introduction. He is the ex-academic chairman of IAPMR. He is now consultant physiatrist of Mohana Orthotics, Prosthetics and Rehabilitation Center. He is head of Sanjeevani Cerebral Palsy Care Center. He has a lot of experience in cerebral palsy. He has done number of workshops inside the India as well as abroad also in most of the Asian countries. So it's a privilege for us to listen from Dr. Feroz Khan. And today we have with us Dr. Sanjay Das. He is my teacher, and he is also the ex-director of SVNIRTAR, and also he is ex-professor head of the Department of PMR, AIIMS Bhubaneswar. He has a long experience in this field. He is one of the eldest or most pioneer rehabilitation surgeon of India. And he is also the president of Odisha Association of Physical Medicine Rehabilitation. I welcome you, sir. Before starting the webinar, I would like to request the chairperson, Dr. Sanjay Das, to say a few words about the webinar. Over to Sanjay, sir. Sir, you are muted, sir. Please unmute yourself. Sanjay sir,
Oh.
please unmute yourself.
Okay.
Sir.
Okay. Thank you, Dr. Pavitra. At the outset, I want to congratulate as well as welcome Dr. FEROZ Khan, who has come to our webinar. Since a series of webinars is going on by NIRTAR and Odisha Association of Physical Medicine and Rehabilitation. And the key man behind all this thing is Dr. Pavitra Sahu, supported by NIRTAR Director, Dr. S.P. Das. So it is a good venture, I'll tell, that Dr. Pavitra has taken so much interest. I think the maximum number of webinar has been done by Pavitra Sahu, taking with other eminent faculties all over India. And he has done a good job. Many people are listening and they were enlightened by this talk and the subject choice. So regarding
Yes, you are audible. Please go ahead.
Yeah. Then let us come to Dr. FEROZ Khan, who is very close friend of mine. Once upon a time, we are meeting each other in all conferences. He has produced a lot of papers, and there is no conference in which he has not read a paper. And I welcome you for coming to this seminar and to enlighten the PG students as well as the physiatrists, that they will listen from you how single-handedly pain management can be done by you in your clinic, particularly how a person is benefited by a single-handed person, which will be very beneficial. You have vast experience. He has vast experience in cerebral palsy management, and that is very much burning subject nowadays. Everybody is interested to know how to manage the CP patients, particularly the spastic type. Every day, daily there is a change. Every day we are finding changes in the management of cerebral palsy. So over to Dr. FEROZ Khan, who will tell us about single-handed management of pain in a clinic, in a cerebral palsy clinic. Over to Dr. Pavitra.
Sir, I welcome the today's speaker, Dr. FEROZ Khan. So over to FEROZ sir.
Oh, thank you. Good evening to all, and thank you very much for giving me this opportunity to speak to you again. It is always wonderful to talk to all of you, and you have been very patient listeners and tolerating for years. So this topic of mine, why is topic is a few days back there was a video in Physiatrist group that one doctor was posted in PMR department. And I could see that the video was shown, and I could see one table, one chair, one X-ray lobby on one couch. This is how I started my career long time back. And I thought this is the starting point of many other physiatrists, because the number of physiatrists are many now. There are so many patients. Posts are vacant, and sometimes you are posted in a prime municipal like AIMS or a public headquarters, district headquarters. But there is a big expectation from you as a physiatrist, from your colleagues, and from the patients. Even though we are given only a chair, and even though we have been taught that it's a rehabilitation team and so many things, but the patient, he doesn't know anything. He said he has a pain, he comes to a doctor. That's all he knows. Okay. So today I take you around the journey where I went through, and I think what you can do easily is, it is not a big deal, but you can immediately, easily you can do find out. So what is a single-handed approach is nothing but you are all, there is no therapist, there is no nurse, you are alone, and you have to prove your presence and justify why they have posted you there and why you started the clinic and how you are going to run it. Then the most common people who come to you is pain, because pain is such a thing that people may get relief, may not get relief. Pain is recurrent, and there is no end road for pain sometimes. Sometimes they have pain in the shoulder, and after 3 months they have pain in the knee. It all keeps on going. So that is a reason why people look here and there for cure. Okay, so this is one of the reason. Other one why the pain patients come to you for a physiatrist. But unfortunately, they'll come to you with all investigations are over, with polypharmacy, polydiagnosis, poly-investigations. Still the pain remains, and they come to you, and you have to do something which is going to relieve his pain. and prove that you are a very important member of the medical society. This is the important thing we have to understand. So I'll try to share the screen now, but I am not so good in all these videos. So please, you have to bear with me for any. Okay, right. Yes. Clinical physiatry. What is clinical physiatry? Like clinical medicine, isn't it? Clinical physiatry means you examine a patient, you here is complaint, examine the patient, come to a diagnosis, start treatment in your clinic. This is what happens in a clinical exam, isn't it? When you are a student, when the examiners come, they will not give you all investigation. They will ask, give you a patient, you examine, and you give the diagnosis, you give the differential diagnosis, you discuss the treatment, and come out. This is what the clinical physiatry or clinical neurology, clinical medicine literally means. Okay, so we are going to go in that line, that how we are going to approach a patient to tackle his pain and dysfunction in your clinic or in the hospital, wherever it is. Now, going a little bit history, find out what is physiatry. Literally, pick up from Greek, this is called nature, physis, and iatry is healing. When they combined these together after the Second World War, they coined the word physiatrist. Natural healing. Are we natural healers? This is a question, isn't it? There are so many natural healers throughout the country and throughout the world who claim to be better than mainstream medicine. You must have seen in Corona, everybody is become a natural healer. If yes or no or maybe, then what, where and why we fit into the changing medical system and facilities? Medical system is changing. It is completely, what I studied is completely different from what you guys are seeing now. It is a change, is acceptable, after all, it's a science, so we accept the change. But you have to prove what is my place in this. Okay. So we had fortunately, I had a lot of international experiences, and I always tell the neurologists that what do you expect from a physiatrist? They said, we want a physiatrist to give us the solution for the problem. They got stuck ups here and there. For example, the neurologist says that it is a stroke and the patient has the left side below amputation. Neurologist cannot manage, nor the physiotherapist can manage. So they have to depend on this in such situation in an institution. Okay. So there is a place where we fit in the big institutions. But everybody is not lucky enough to go to a bigger institution. You may be at home, maybe somebody have to start practice, because the services are required are huge. And how can we do it? How do we do it? Mainstream professional approach is based on signs, symptoms, and investigations. You all know when somebody comes to your clinic, a chronic pain management or my clinic, they already have a bag which contains MRIs, series MRIs, all blood tests, a lot of medicines in their pocket, and they come here. There's nothing much you are going to do for it, isn't it? So they treat mostly signs and symptoms. Everything is done by us. It is good for us to come to a diagnosis. Then we treat the individual. This is very important. See, if a 40-year-old man comes with pain in the right shoulder due to impingement pain syndrome, the diagnosis for mainstream medicine is impingement syndrome. Whereas for me, I take it as a Mr. So-and-so has pain in the shoulder, he can't drive a car. This is my diagnosis. I know I've been making, so you know, but how does it affect his life? That's very important. That is where we have to differ from others, and we should focus on how I am going to improve somebody's life, even if he has a periarthric of shoulder, which I cannot adhesive capsulitis. I cannot get full range of movement in 3 or 4 days. But how I'm going to improve his life? That's very important. And we improve the function even there is pain and dysfunction. We use a thinking mind, analytical mind to suit our treatment approach individually. We can't be corporate. The facility that because patients will come by the time we come to you, they exhaust all resources, nothing much to pay or anything. So you would have a thinking mind and suit the patient individual correct treatment what you are going to do. And you have to use 10 flexible fingers to feel the musculoskeletal system and talk to the brain with sensory input. This is very, very important. Any workshop I do, first I give them a sponge like this to my participant, ask them to squeeze. Everybody go like this. Sorry, physiatrist should go like this. You should have 10 flexible fingers. In thinking mind, you can talk to the brain, you can do wonders in the patient in your department. Okay. You may start, these the physiotherapists will do it. Doesn't matter. Everybody does everything in the world. But patient is your responsibility. He is sitting in front of you. He has come with pain in the shoulder. You have to relieve it. That's all. Okay. Then we must have a humane approach. This is very important. We can't be a commercial approach. We have a human approach. Believe me, human approach may not give you money today, but later on they will give you a lot of money and a lot of pain. Be patient. Clinical physiatry, as I told you, you take history, you look for symptoms, signs, come to a diagnosis, answer the examination to the examiner's all questions. But in the clinic, the client is the examiner. You think like this. The patient sitting in front of me is the examiner. I have to come to a diagnosis and I have to make him realize the skills to make shine in his like immediately. That is very important. The patient has come to you, maybe after chronic pain. Most of the acute pain do not come to us, or a result of acute pain with a chronic episode, or a heel pain. Getting up in the morning, he can't go to the toilet. All these things are interfering with the lives, and these few minutes of pain they suffer and they get up in the morning. You should realize how it is. And you must use your skills to make it shine. That means next day, by the time he leaves the clinic, he should go without pain. And next day morning, you should get up without pain. This should be your target. That means you are making a change immediately. This is the practice you have to follow, and very soon you will get it. And how can be different? You should do something others do not do, or do something better than what others can do. Good knowledge in anatomy, physiology, and physics, and apply it in your approach. Anatomy, you all know, you should read every day, or at least you spend some time doing anatomy. And physiology, how your different structures work. And physics, because you are going to use a lot of biomechanics, you are going to talk about some equipments. You have to be a little bit what is ohms, what is resistance, what is volt, what is ampere, what is milliampere. Because the patient may ask you, what is this TENS machine? You have suggested me how many milliamperes. If you blink, it is not fine. You must know a little bit of physics regarding your treatment, the basic. And thinking mind. And please put your hand on the patient, feel the tissues, talk to the brain, and try to manipulate both. Okay. This normally I show you in the workshops, but I will try to show you some videos. The fundamental thing. Our body has an excellent curves. There is an anterior curve, there is a posterior curve, and there is an anterior curve. These are the three basic curves, which is the foundation of the body. Because the front, you have the abdominal muscles, the back with the gluteal muscles, and here you have the shoulder girdle muscles. So these three muscles are responsible for keeping the okay. And there are some small muscles which are postural muscles, which do not big movement, but they make some adjustments when you change your position. Okay. So you have to find out what is the patient's posture when they enter the room. And we all think that somebody may be specialized in hip, somebody may specialize in neuro rehab, somebody may specialize in pediatric rehab, somebody in orthotic prosthetic. But remember, our body is one, it is interconnected. in function, you can't separate each other. You have to see the person as a whole. He may be a patient with heel pain, or he may be a patient with stroke, or he may be a patient with spinal cord injury, or he may be a patient with rheumatoid arthritis. So this is the very important. So if anybody who has any problem about the spine, about the pelvis, okay, then you have to have a good abdominal muscles, good glute, and good the trapezius and rhomboids in the back. Any problem, don't worry. If you are able to have good these muscles, the pain will automatically come back. Because most of the patients who have pain due to musculoskeletal dysfunction is because of the change in these curves. Okay. We are becoming flexed now. Our universe is becoming a flexed universe, especially during this pandemic, because all the we are on flexion always, texting and webinar and all these things. So we all going to get a lot of dysfunction in your different part of the body. But you have to remember there are 4 major load-bearing joints. One is the shoulder, one is the hip, other is the knee, other is the ankle. These 4 are in perfect alignment. And these 4 are designed to be in perfect alignment, plus a dynamic and a static alignment. Okay. So whenever there may be a problem in the posture, the alignment will change, or if there is a problem in the alignment, like fracture with dislocation or fracture with deformity, the alignment may change, the posture will try to adjust. Okay. So alignment and posture is one of the foundation on which the human function is built on this. And if you see from this view, both the shoulders are in level, both the hips are in level, and we have the right shoulder and left hip, and left shoulder and left hip are connected by a tangential vector. What does it mean? I was thinking why it is like this, and I found out that these symmetrical joints, the shoulder is symmetrical to hip, because it is same movements like flexion, extension, abduction, adduction, and rotation. Okay. And we have the knees, which are symmetrical with the elbow. If you have ankles, are symmetrical with the hand and wrist. Okay. Why I say this? Tomorrow morning, you go to your clinic. If somebody has pain in the right shoulder, okay, and his left shoulder is free, look at the range of movement on the right shoulder when there is pain, and ask him to use the left shoulder 5 times normal range of motion, and ask him to lift the right affected shoulder, the range of motion will be more. Why? Because they are connected. They are, human body is an active body, not passive. It's an active body. The best machine is created, and we are supposed to take care of it. Okay. So the symmetrical joints talk to each other, and they are bilateral, bipedal. One half of the body is here, and one half of the body is here. So suppose in a hemiplegic patient, if the right side is affected, first I go and strengthen the left side first. Then I strengthen right and left side. Then finally I will strengthen the affected side. This is the stage you have to go one by one, so that you are going to take whatever the input from this shoulder, which goes to the brain, and you have to remember the corpus callosum both on the cross, isn't it? Right. So the right and left cross, they are not separate bodies. You may separate, but the brain is connected. So with this input, tactical input and proprioceptive, I can get more movements here. The same thing works with the pain. If somebody has pain in the left shoulder, you open on the right shoulder, and believe me, you will have immediate relief of pain at least for a few hours. This is what I say, immediate change. And it is a single-handed approach. You don't need anybody to tell you this. Okay. And we have a lot of these people who are asymmetrical. If they plumb line, see, it is going somewhere. Here it is, neck is forward, too much forward. and here the right leg is pointing somewhere. This is very common in any patient who comes inside your clinic with pain in the shoulder. Please start from the neck and come down. Don't straight away go and put your hand on the shoulder. Somebody dips to the knee or any pain, and for example, I tell you, ONE is the most common diagnosis which comes to any PMR patient because people have done everything. Somebody has done all intervention, everything, nothing happens. They say go to therapy and they will take care of it. In treating a knee has a lower end of femur and upper end of tibia. So in the knee, the femur has an upper end which is in the hip. Most of the patients who have a ONE or knee pain have a hip problem. If you just examine the hip, you will see there will be some stiffness. Okay. So what I do is I just relieve the hip stiffness. The pain in the knee will come down. Why? Because it is always stiff. The hip is not affected by disease or ONE, but it is just stiff to adjust for the knee problem. Okay, so you have a comprehensive examination of all 4 road-bearing joints bilateral. This is a different type of dysfunction you can see. Somebody has a foot like this. Somebody has dropped shoulders. Somebody has a old age person, and here you can see osteoporotic. And here is a young girl who is stooped forward. This girl is a little straight, but she has some problem in the feet. So these are the main people. Different type of people are going to approach you for different pain symptoms. Okay. Now, this is a book I picked up from US long time back, and I read this. And this is written by one Pete Hiboski, who is an anatomist by profession. Then he started doing a lot of work, research and posture on this thing. He has treated millions of people, and he has a good approach. Always he must have a thinking, open mind, think out of the box. Reading just your PMR books are not enough to manage. Right? You have to read books outside your syllabus so that you will give a better approach to your patient than just reading the conventional textbooks. This books has given me really opened my mind to look the pain in a different way, which I found useful, which I want to share with you. And diagnosis. This is the typical you have to. Where is the lesion? For example, somebody comes with a pain in the tennis. Okay, right, epicondylitis. How many years? 6 months. These are the people. Nobody, you not get a patient of 1 or 2 weeks. It will come only after 6 months. Okay. Where is the lesion? Lesion is the common extensor tension origin. What is the lesion? Is it traumatic or it is a repeated stress injury, or it is part of a generalized disease, or if it is past of any congenital abnormality is there, or if there is a post chronic trauma case, what is the lesion? And why is the lesion? Why it is there? This is what you have to understand. Why this man has got? If you are going to say that impingement is common in drivers, every driver doesn't get an impingement, isn't it? And only few will get. Why? You have to find out why this man got PA, why this man got pain in the knee. Everybody gets up in the morning and walk, but why somebody gets pain in the morning? Isn't it? Both the feet look similar. There's nothing special. Both the feet will look similar. A right will left look similar. There's no pain in the right, there is pain only in the left. Why? They will think, why? Why is the lesion? And how bad is the lesion? Is it a progressive? Is it a regressive? Is it a recurrent? How does it affect his life? Okay. And what we can do about it. These are the questions you must ask when a patient sits in front of you in the clinic. Where is the lesion? What is the lesion? Why is the lesion? How bad is the lesion? How it is going to affect his life? And what I am going to do this. If you know the answer for this 1, 2, 3, 4, you know the diagnosis. How bad is the lesion? You know next this what you are going to plan. If it is severe pain, your plan is different. If it is a chronic pain, plan is different. If it is occasional pain, plan is different. And how it affects your life. I always ask all my patients who are sitting there in front of me, how does it affect your life? And believe me, the moment we ask you, there is a brightness in the face. This is the only doctor who asked me how it affects my life. They will say that all sort of funny things or very emotional things. And I remember I did a study, as a first study as a postgraduate student. My paper was perennial hygiene in periarthritis of shoulder. So everybody was making, I presented in the AIMS New Delhi. I got up in third place or something. So you analyze people those days, we use the left hand for cleaning after the toilet. If somebody has severe pain, external rotation, how they will manage. You will be surprised to know that study I found out, women avoid going to the toilet because the pain is so excruciating. They become constipated. They avoid going to the toilet because of the pain. How bad it affects life, right? That you have to find out. How does the knee pain affect you? Then they will use 1, 2, 3, 4. Then get the priority and attack them. Right? Otherwise, this you see, examine a patient with periarthritis shoulder, no changes, okay, PA, okay, go to physiotherapy, pain relief, ultrasound. And the physiotherapy, they're very smart. They want to give ultrasound, they want to short wave, the next day they want to get interferential, whatever machine they will use it. That means we are walking in a jungle where we do not know where to go. Right? We should not be like this. We should guide them the right way. Right? That means what? The patient who comes to you with a pain in the shoulder or heel should walk from your clinic for pain. Or there should be smile in their face that, yeah, I'm feeling better. Okay. Can we do it? Yes, we can. What are the treatment options we have? So far, the patient comes to us. One patient is always passive. He keeps quiet. People took medicine on his mouth. This tablet, Ayurveda, oil, kashayam, all sorts of things are there. And injections, left and right, from the 10 rupees steroid to 15,000 rupees Canvisic, interventional pain management, etc. I don't blame them. They all have to play. But normally, you have to use a steroid or intervention when it interferes with your life, interferes with the function. Otherwise, you don't do it because it is there. Okay. And patient is active, that he is doing physiotherapy and exercises. And what are you going to do? This is the most important. What you should do. I'll show you one small video. Okay. Are you seeing my screen?
So only PPT is visible. Video is not visible.
So
No, video is not visible, Dr. FEROZ.
I've not started
We
it.
are only seeing your slide. Yeah, start it.
Is it visible? Not.
No.
No. Okay. I will do anything. I'll stop sharing. Okay. Let me close this. Will we stop share? Okay, now I'll come to you a little better when I think our friends will help me. Okay, now no problem. So this is a posture I ask patients to do. Okay, it may look funny, right? What I get is I get a nice lumbar curve here. and I give a nice hip extension here, and I give weight bearing in the shoulders. I keep the neck little up, the little size, I put the neck down. This posture, which I use for somebody who has a problem in the hip, foot, and in the elbow. Okay. This posture is going to get the patient or the body, the lumbar curve, which you have lost because of prolonged sitting like this. So this is one problem which we have to do. So if I put the patient on this posture and ask them to walk, after some time, they will feel the pain is less. You may ask why, isn't it? So if we go out, when there is a perfect alignment of this curvature, and all these four joints are brought into alignment, after the patient spends 5 minutes in the posture, they will get better, full well-aligned body. So the pain will come down. I don't say the plantar fascia is completely gone. The pain will come down, okay, and the pain will come down. But that is not another story. I tell them, do you feel better? Yes, I feel better. Okay, then do the exercise at least for 2 weeks and come back to me. The patients were not coming back to me, and I thought maybe something wrong. But what happened is then I realized after 2 weeks they were sending another patient. That means our treatment worked, so they want to refer somebody else, right? Now, can you tell me how to stop sharing this video so that I come to general one? Yeah. Stop share. Yes, yes. Here I will share. Okay. I will share screen. Entire screen. Okay. Now I think you'll be able to see this. Okay. Okay. You see this? Are you able to see this picture? Hello?
Yes, sir.
Yes.
Yes, you can see. You can see it.
Yes. Okay. So you have what you should do. You are, as per my first introduction of physiatry, I am a natural healer, or no, it's not like this. But we have to use everything in your hand. The best is 10 fingers. Okay. Work on them and try to reduce the pain, and so that the pain which is bothering him in his function, bring it down. Okay, this is what I do. I have a lot of videos, but nowadays the patients are not willing to post for videos, so I cannot show them. Okay. Then what are the common musculoskeletal issues? Right. Neck patient will come neck pain, dorsal pain, shoulder pain, lumbar spine, hand, elbow, pelvis, hips, knee, ankle, everything is there. Please remember, if there is a neck pain, you have to examine this. Dorsal spine, the lumbar spine, pelvis and hips, knees, ankle and feet. Don't just stop with the neck. You will find the answer somewhere. because all these joints are connected and there are muscles which cross these joints. Okay, and if there is a muscular dysfunction, then there can be a problem. Why I say this is muscles move the bones. Okay, then bones move the joints. Right. The muscles are under control of the body. So muscles play a very important part in putting each joint in its place. So the problem which is in the joint, which can be weight bearing or a non weight bearing joint or a functional joint or a static joint, sacroiliac joint, the muscular function along with the sensory input is of paramount importance to maintain the joint and function. So we have to examine the patient full. It may not take much time. You can just put the patient in this, ask where is it? Is he somewhere problem here or somewhere problem here? Somebody may have a neck pain, but he may have a shoulder which is down. Okay, so we have the neck pain is so severe you can't touch it, but if you are able to take the shoulder up, the neck pain will come down. So they are all work together as a unit. Okay, so this is the one which you have to keep it in mind when you are going to treat the options. Now, how do you come to this diagnosis and what are we going to do? For example, say neck. What is the importance of neck in human body? Neck is required for neck control, for vision, for vestibular canals to work properly, for swallowing, okay, and cognitive learning. So these are the most important thing in the neck. What is the important thing in shoulder dorsal spine? So the neck becomes flexed, come forward. Why? Because there is a two problem. One, our job needs we are have to sit down always. So we bend forward and work. This is in our age group, we can accept it. But youngsters who are fit, still they have a neck forward. If you see them carefully, most of them may have a little paunch or a tummy, and they want to keep their abdominals tight, abdominal muscles tight, so that they look fit. So when the abdominal muscles contract, the neck comes forward. If you see the big, really gym people like this, the neck is always forward. If you see the number one winner, he'll be like, but neck is forward. He wants to show his abdominal six packs, neck has to come forward. So these are two things, common things which can see that why the neck is brought forward. And the simple test for this, ask him to stand and relax his abdominal muscles. The moment you relax the abdominal muscles, the neck pain will disappear. You can try after going home. If you have difficulty moving the neck, going up and down, then relax the muscles, then your neck will move better. Because the abdominal, see, I am treating the abdominal muscles for a neck pain. Because both are correct. Okay. Now, dorsal spine is another victim of the abdominal muscles, because people want to have a abdominal curls, and these trainers in the gym, they teach him you must have a abdominal curls and this and that and like this, and the dorsal spine is also going to have a complete forward bending. They can get a pain on this. Shoulder, it is the most versatile joint with movements and concern, but it is a very, very emotional joint also. When you are depressed, your shoulders are down. When you become a pensioner, your shoulders come down. So the shoulder is related to your emotional aspect. The shoulder and the hip are identical joints. So tomorrow morning, any of you, if you have a patient with a shoulder pain, please make him stand and ask him to extend and externally rotate the hip. Okay, 10 times, and I see the range of motion. I tell you the range of motion surely improve. Why? Because shoulders and hips are identical joints, and shoulder is drooped forward, and you are going to extend the hip, the shoulder is going to come down passively. So the patient who comes with severe impingement syndrome, You just give them strengthening exercise for the glute muscles, and you can see that they'll be 10-15 degrees of going. What we did, I did not do any magic. I just did this. I brought the patient into this or into this. That's all you do, nothing else. You can see the intensity of pain will come down. But I tell him you exercise here, he said, no, no, why? My pain is here. My pain is here. Okay, I know, your pain is here. Oh, it doesn't matter, do it. How is it? How is it? You're okay, okay, no problem, do this, go on, do this. So with this small input and trying to go deep inside the machine which you are in front of you with the patient, and that's how I can manage this. So these are the few, it may look little, I was also did not believe this in the beginning. Then when I started to treat this, then I realized, yes, there is something. Then I went deep inside, I found this. Elbow. Elbows are very common. The most common patient who comes with elbows, tennis elbow, isn't it? Lateral epicondylitis. Why? Not known. There is a common etiology not known. But what is the problem? Epicondylitis. Please remember, young postgraduates, when you write supraspinatus tendinitis, this is only you are telling that pathology that supraspinatus tendon is irritated. There is information. It is not the diagnosis. It is not the etiology. Okay. So you have to, of course, you treat the supraspinal tendinitis with your medication, with your intervention, whatever it is, but you are just giving a symptomatic relief. You are not going to tackle the original problem. That is the reason why it is recurring. Okay. And after 1 year, it dies by itself. But it will have a dysfunction. Right. So the most common cause for elbow is in our lifestyle, we hardly extend our elbow. At least when you are not married, you will extend the elbow, but once you are married, your spouse is there to help you to get everything for you. Right? You hardly extend your elbow, and one fine morning you extend your elbow, there is going to be a dysfunction. Why? Because your whole body is in flexion. See, the treatments I had to put them in extension. For a 3-minute period, you can see the pain will come down. Yes. Hand is of the same. Carpal tunnel syndrome and all frequent synovitis. All this, a pregnant lady, first child, the most common first recurrent synovitis, isn't it? Not because she's pregnant. You see only in the higher class group. Because in the lower class group, labors, they are not flexed, they're always extended, isn't it? They do a lot of job. In higher class group, they're always flexed, they're taking rest, and they leave the child, there's a lot of a problem. And this is always a big problem for the treat. So the grandmother will, the mother of the grandmother of the child will come, she will develop one side because they're handling the child for the first time. The problem is not the your tendon, the way you will carry it. You just extend yourself, you will not get this stress on the tendon. Lumbar spine, back. Yes. I have to do that. Please, if I am finishing time, please remind me. Okay. I don't want to keep talking. Now, I told you there is a curve here, curve here, curve here. And what is keeping the curve? Of course, there are bony articulations perfectly aligned and ligaments should talk to keep them there, but this spine is mobile, isn't it? That means it is going to be go out of alignment like a fishing rod. Okay, like somebody is fishing, the fishing rod will go. The same way, if you bend down and take something, your back is going like a fishing rod. Then you try to pick it up. But what keeps the spine in this curve? What takes them away from the curve? And what takes them inside the curve are the muscles. The muscles, the front abdominals, the stabilizers. The hip extensor, they are stabilizers. The rhomboids, they are stabilizers. And you have the erector spinae, which work as a postural muscle in the upper half and as a mobility muscle in the lower. And the small muscles, which is interspinous muscle, the longest small muscle in between the vertebra, they maintain the posture They are just the sensors. Unfortunately, in all back pain, we leave the muscles, we attack the disc, we attack the joint, we attack this, we attack that. Yes, this generation gives pain, facet degeneration gives pain, disc prolapse gives pain, and your spondylolysis and spondylosis give pain. But what made them to develop this is your muscular imbalance. So you have to go for the muscles in the beginning, then you go for the main problem area, like you are going to do surgery, or you are going to do interventional pain management, or you are going to give some injections, facet injection, fine. They're all fine, excellent relief pain, but you have to work on the muscles which were responsible for developing this. For this, you do some exercises so that the simple is make the patient sit in the chair and develop the curve. The pain will come. We'll show you some procedures after that. Okay. Then pelvis and hips. Pelvis and hips. Pelvis is a gift of nature, they say. This is the first time when the man became erect. He became erect on the pelvis. Right. The pelvis turned into an erect structure. It is a stable fulcrum on which the spine is a stable platform. Spine is resting, and the fulcrum, the spine can move, and you have the hip, which is the this pelvis and hips work together to be like a seesaw and a seesaw. They have good reciprocal innervation, and they are able to perform better transferring force. You can divide your body two halves. The upper above pelvis is a precise one, and the lower is a very strong one, isn't it? Right. So there is a meeting point. So a lot of problem dysfunction can happen in the pelvis, but pelvis is very huge and it is weight bearing. In all the postural correction, what we do is we try to bring the body weight on the pelvis so that pelvis can take more body weight than putting on the joints. For example, somebody flex like this, his body weight is falling on the joint, not on the pelvis. I try to do this so that the body weight is falling on the pelvis, the knees are free to move. Then knees. The most important thing you have to know about the knee is that knee is a very specialized joint neurologically. Why? Because it is not a stable joint like an ankle. It has so many ligaments, or the hip, which is a heel column socket joint. It has a variety of movements. It doesn't have much, hold there. Variety of movements that controlled by the brain. That is why once you reach 40, 50, 60, when your cognitive function comes down, when your balance comes down, the way to be more symptomatic. Please, anybody has any lower leg problems, either in the hip, knee, ankle, or foot, plantar foot, please examine the balance. You may find there is a single leg balance affected, there's some balance activities there. So that may be contributing to the pain because they are trying to use the muscle most of that hold the balance. So you have to comprehensively examine the balance neurologically and give some balance training. They will feel much better. Okay. An ankle is the one where the body weight is born, it's transferred, and it is taken. The smooth movement of the tibia over the ankle, rocker 1, heel touch, the movement of the tibia over the calcaneum, rocker the talus, rocker 2, and take off rocker 3. This beautiful movement is done by the ankle. Ankle is the one which gets the maximum bend where the three times your body weight is falling on the ankle every time you walk or run. So ankle pain is always related to any problem in the hip and the knee. If there is any ankle sprain, all ankle problem, or even foot, whereas flat foot, whatever it is, they are considered the loading disorders of the foot. Okay, anything plantar fasciitis, I look at the hip, I treat the hip, I treat the knee, then I come to the ankle. Because they are taking the load of the hip and knee. So the hip is not properly loaded, or the knee is in varus or valgus, you are bound to have a pain in the ankle. Right? And vice versa. The ankle is broken, then the knee and the hip will take the brunt. So you have to think and classify that is where is the lesion, why it is there. Ankle and feet will go together, and I'll show you some pictures. This is one posture which is going to put the alignment on the back. This is useful for your hip problems, for low back pain problems, and your problem for your tennis elbow. You can see that I have extended the elbow fully with a good weight bearing proprioceptive, which normally we do not do. This another posture. All these postures are maintained for 5 minutes, not more than that in my clinic. I get a good lordosis here and the extension of the spine, dorsal spine here, extension of the hip and the lordosis. This is a good one to get a disc herniation. You try to push the disc inside, you'll get good relief of pain and you get the lordosis. This is the posture I give them for elbow pain. Stand against the wall, stand with tiptoeing and keep it up for 1 second, 1 minute in this position, and in this position, 11 o'clock position for 10 o'clock, 1 minute, and 1 minute in a 9 o'clock position. Try this tomorrow. Anybody who has any shoulder hand pain, just stand them like this. Then after 9 minutes, ask them how they feel, the pain will come down because they have taken the load away from the elbow, always sitting, standing, everything with the elbow. We have taken the load or offloading the elbows. Immediately the pain will come down. So what is the program? Every day to offload your elbows for a period of 5 minutes. The pain will come down. Okay. And this is how you all know that the wonderful position here. Good for the shoulder, hip, knee, ankle and foot pain, neck. This is a universal position where there is an excellent relief of pain because there's a correct anterior curve with the nerve, there's a correct posterior curve with dorsum, and a good lumbar lordosis, and both hips are aligned, both knees are aligned, both feet are aligned, and this is an excellent for offloading the lower limb weight bearing joints, knee and ankle and shoulder. Remember, shoulder is also a weight bearing joint because it is bearing the weight of the two upper limbs. Okay, the two upper limbs are attached to the torso by the shoulder. So shoulder is a weight bearing joint. So you have to, any patient who comes in severe pain, put them in this place for 3 minutes, come back, how do you feel? You won't believe some of the housewives or some of the busy young people, they'll sleep off. Immediately they'll go to sleep. Because it's so soothing position. Our brain will appreciate sensation. There is a good sensory system. They will. Okay, this is the best position you can give. Any patient who comes with any pain, put them on this position 3 minutes. You won't see them sleep comfortable. And this is a genu valgum. This is a boy who came a few days back. You can see there is a genu valgum. Father is very much worried. So I just isolated contraction of the quadriceps. I taught the father how the child has to contract the quadriceps. Just it's just the last few degrees of extension. Okay. This upper correction. Immediately in the clinic, I cut it to intermallear distance and brought it down. It is possible. Okay, because when there is a valgus, there is no alignment. If the muscles, if the joints are not aligned well, the muscles cannot work well. The muscles work better when there is a good alignment. That is why one of the reasons why the pain relief we use alignment, and for neurological rehab we use alignment with your crouch osteotomy and all surgeries which you do, and surgery and cerebral palsy is to bring a best alignment for a good liver arm disease, isn't it? The liver arm. So I am able to get this amount of in one sitting. So the parents are satisfied and they do it for me, and after 3 months I see them, they are almost corrected. Why? Muscles move the bones, not the braces. muscles move the bones. You have to use the muscles. Yes. This is the neck dysfunction. You can see I have put a small marker that how far his neck has gone forward. The ear should be on the line with the shoulder. Even though the young fellow, the most common reason maybe is putting his abdomen always tight to look thin. Okay. So there's so much gap, and by slowly, by your postural correction and alignment, you can bring it back here. Then pain will come. Suppose he has neck like this, okay, and imagine his body weight is going to fall on the knee, not on the hip. So if you bend forward like this, he may have a knee pain or a foot pain. I correct here, so that I get into the alignment. And these are the two best positions which all must have seen in yoga. But what is it? I don't want to hear you are offloading the neck. People neck pain is only nagging. They come back from the office. They got a lot of problems. So much pain. They said, I cannot sleep. I have this problem neck. Lie down like this, Baba, for 3 minutes. Okay, immediately pain will come down. Why? We are putting the alignment. We are offloading. Imagine the weight of your head is 5 kilos. The weight of your head is 5 kilos. It is constantly put in front of your back for 12 hours, 6 hours in a day. You think it's natural that neck will pain. You just take it back and put it like this. This is another perfect sitting position where we are going to align the upper body. Neck curve, posterior curve, and spinal curve, and shoulders in line. So any problem in the upper part of the body, and you are offloading the lower. Everything is one line. Tomorrow you spend like the 3 minutes, then you see you will feel much energetically better, and pain will be less. And this is the wonderful question I have discovered is, whenever I check a Faber test, for anybody who has pain in the foot, pain in the knee, or pain in the low back, or pain even in the shoulder, I check the hips. If there is stiffness, I put them prone, put a pillow, so they extend the hip. In the process, you can see the neck anterior curve, you can see the posterior curve, you can get the lumbar curve, you can the hip in the extension, the knee in the extension, and this position also, we put them, and in 3 minutes, they walk out that they do not have pain in anywhere in the joint they have mentioned. It is a wonderful position, and you can immediately relieve the pain and patient have very good confidence. Then how frequently you do this? Normally, I give a sit-up exercises, but not more than 20 minutes. I don't have to do this body exercise 3 times a day, 100 times. No. 20 minutes daily, once a day in the early morning, because the rest of the day your posture is in a very bad situation. So correct your posture and go before you go. And number 2, twice a day if the time permits, continue for 2 weeks. After that, if no pain 48 days, you can stop and do a general fitness. So 2 weeks is the duration which all that they give, and I see them back, and they will come if there is any good relief. So to conclude, you should gain good knowledge of basics and apply it in your. Gain good knowledge and apply it. Getting knowledge enough is not enough. You have to apply it in your treatment. Think out of the box. Try to improve the function. Should take active part in the management. This is very important. You may be a busy physiatrist, no problem. Take 30 patients you are seeing. That doesn't mean you can see a patient and send him for any exercise and forget about the patient. You don't know what's going on. This is not allowed. You have to take active part in management. The patient comes to you, the file is in, you are in charge or is going to leave. Put it in your mind. Then your life will be very easy. Then you will understand what you are in the department. So some of the young colleagues ask me what I am doing in my department. I do not. There's a big discussion. They want to change the name. They want to change all this. Because if one patient comes, you satisfy him, he brings 10. Right? So if you are going to improve the function of the patient, produce pain relief in your clinic, before he leaves there, you take active part of the treatment. Then the long run, your colleagues and therapists will start suffering the cases for you. This is what I have seen in my. people who refer me as a therapist and orthopedic surgeons and patients like this. So they send me a patient, sir, I don't know what to do. Okay, you do like this. But don't think that giving therapy or giving advice is not your domain. There is no rule, there is no line. Patient is important. What is important? Patient is important. Patient is important, his pain is important, his dysfunction is important, his life is important. You have to think like this. And I thank you all for giving the opportunity to share my experience and thoughts. You are always welcome because I conduct some workshops to who are interested students. In my facility, I can take 4 people. It is a 6 days course, morning till evening. You are always welcome. It's free. You are always welcome to come. I am 70, I'm turning. I don't know how long years active life I have. But if you want, you come there, you stay with us. Seeing is believing, so come and you are always welcome. But you have to make your own arrangement for travel and stay and this. And we'll try to instill the confidence which in you. That's what I can promise. Thank you, doctor. I'm ready for questions.
Thank you very much, sir. Thank you very much for exploring unexplored areas of physiatry. I mean, many of us are not aware about this part. It sometimes looks like a magic that the result we are getting. So, because every physiatrist is not a doctor only, he is a physiatrist. One should not think that he is a doctor only, because a doctor treats a disease, but a physiatrist treats disease as well as a function. So, it's my sincere advice to all young physiatrists that they should not think themselves as only doctor. They should think themselves as a physiatrist. So that will think more, will give more emphasis on a functional aspect rather than only disease part. So thank you very much, sir. Even we are not aware about those things. We'll try to implement your tricks and tips in our clinical practice also. And second part from this lecture, that one should not try to take a shortcut for the treatment, like putting just a bundle of steroid or putting a course of analgesics and just relieving the responsibility from our shoulder. That is not enough. So one has to think in other ways also. What are the other aspects? What are the functional limitations of the patient along with that pain? So that part also one should think of. Thank you very much. I would like to take comments of first our chairperson, Dr. Sanjay Das. Then we'll see any questions in the chat box. Sanjay sir, please.
Yes, Dr. FEROZ, this is a new.
Hello.
About this is a new approach. Are you able to hear me?
Yes, yes.
Yes, sir. You're audible.
This is a very new approach. I can say, is it some form of modification of yoga, Dr. FEROZ? Because
yes.
you are taking them to one posture.
Yes.
Where they have to sit or they have to stand or whatever it may be, different position of the body and shoulder. So is it they will repeat it or they will be in that position for 20 minutes?
No. I have a set of exercises. The best is when the things are better, I wish to come to your center and then tell the students, seeing is believing. So video is very difficult because previously patients were ready to be video. Nowadays they don't like to be video. It's a separate issue. So basically one arrange, I'll come sometime there and spend 3 or 4 days with you. Then you'll get everything clear. They one position for 3 minutes, 4 minutes. Or the maximum long duration static value, 90% maximum. Otherwise, 3 minutes, 4 minutes, that's all.
Yeah.
Once the body comes to alignment, the pain goes off.
Okay. One another doubt I have. You have shown that the genuvalgum has been corrected.
Yes.
So you have not mentioned in which age and how much time duration.
No, I get the intercondylar distance is more than 10-15. Normally 10 centimeters when we take normal pain in a child. Okay. And if it is when that child, I know it was I think 13 or 14, the child came to me. But in my clinic, I can bring up to 10.
I have the same question, sir. If it is a bony deformity, how can it come down to less than 10? If it is a bony deformity.
That's a very good question. We think it's a bony deformity, but what put the bone there? unless it is a fracture. Or if it is a fracture, there's injury, then there's genuine. But what put the fibula, tibia away from the femur?
Yeah. In case of idiopathic genu valgum, there is deformity. I mean, there is the problem of the
muscle, isn't it?
And
so what can bring it back? What can bring it back? The muscle, isn't it?
No, there are bony deformity. We correct the bony part, not the muscle part in the surgery.
Bony deformity structural, there is a disease. Bony deformity is a disease. Okay, that's all. That's a structural deformity. Bony deformity, tumor, or rickets, whatever, they're all structural deformities, right? That we cannot change. Okay. That's a disease. But there are some dysfunctions. Okay, so you can try this. You take a genuine child, or even people with OA with genuine, older people, make them lie down. Okay, flex the hip, flex the knee, and ask them just lift the quadricep 6 inches from the bed, 10 repetition one side and 10 the other side. Then ask them to stand. You can see the leg is straight, because what put the tibia out or what brought the femur inside, so the tibia is outside, is the muscles. I am just regulating the muscles. So I didn't believe it, but you can try it. Even the patient I can show you, but we are in webinar, we cannot show you. So you try it.
Dr. FEROZ, in children, the genu valgum or genu varum is mostly due to unequal growth of the femoral condyle or tibial condyle.
Yes.
So here the muscle does not play any role. And
growth of the epiphys depends on muscles also, muscle work.
Growth is there, but there is unequal growth.
Yeah, so unequal muscles may be there. I don't know. I'm just telling. You can explore. You can try this. You can take it up. Explore.
Sir, maybe this is for the non-structural deformities that can be corrected by muscle action. Once it becomes structural deformity,
structural, I don't know.
Yes.
I agree, fully agree.
Yeah, Dr. FEROZ, you told that more than 10 centimeter. Book says if the deformity intermalleolar distance is more than 3 inches, then you go for active treatment like surgical plate fixation or orthosis or all other things. But this will not correct after 10 cm. That means 4 inches intermalleolar distance cannot be corrected.
No, I'm not fully correcting. I am bringing it little less. Okay, number one. Number two, because most of the children come to us for a platform. Okay, then we pick up this. Okay, they come to the genu valgum.
Yes. But this genu valgum secondary to flat foot, yes, it will be helpful. Definitely.
So yes. We have to attack it both ways, isn't it? You can only put the genu valgum arch support. I don't think genu valgum will be corrected unless you actively corrected by the muscle forces. That's what.
Yes.
Your point. So most of them come to us for a flat foot. When I pick up this, there's or even the knee pain, they come to genu valgum knee pain. Right.
Do your method helps in OA?
Yes. OA is comprehensive. OA, knee.
No, OA I'm asking in grade 3 and grade 4.
The grade 3, grade 4 is always the graded as a neurolog as per the radiological and this thing. You can see on the road, people with grade 4 walk happily.
Yes.
And you can see grade 1 or 2 going here and there, going for replacement. Okay. So I put the pathologies there, but I put the pain and function in the front. How will he improve his function?
Okay.
Suppose somebody doesn't want to get operated. Operation, surgery, whatever it is, the choice. The patient refuses, what can we do, isn't it?
Yes. Sir, it has been mentioned many times that people come with grade 4, they don't have much pain. They are walking very nicely. But people come with grade 2 also, they have severe pain.
Severe pain. So my concern is pain and dysfunction. Pain and dysfunction. Okay, that's all. I try to solve it.
In grade 3 and 4, Dr. Pavitra, pain is much more than grade 1 and 2. Grade 1 and 2 are manageable. They can manage.
Sir.
But in grade 3, 4, there is severe pain. He cannot walk. He cannot bear weight.
Sir, exactly, sir. But still some patients with grade 4, the X-ray appears grade 4, but still they don't have that much of pain like grade 3 or grade 2. People coming like this. So say many times we say that don't treat the X-ray. Don't treat the X-ray for replacement. They treat the patient. See how much pain is having. See how much of limitation he has for his day-to-day activities. Accordingly, plan it. Sir, one more question.
Yeah.
You have shown your technique for massage over the adductor canal. How only one knob is there, that is upness knob. How it helps in relieving pain from knee?
No, the knee is applied by subvenous nerve. The easiest one is a little bigger trunk. Okay, you can palpate it. Okay, I just stimulate this. That's what they do in ablation. That's what you do in ablation. Radio frequency ablation. That's what you do. You go and permanently damage it there, right? So just give this in this massage for 30 seconds. Okay, and he is able to get up and walk. So I don't have pain. That's all the problem. But I'm not doing damage now. The damage is there. So there is momentary relief of pain in a person who cannot take a medicine. What is the other option I have now? It's the only option I have.
Just a transverse friction massage or anything else?
Right?
It's just like a transverse friction massage of the adductor canal or any direction of massage like in long
just very gently, all four. Very gentle means like this, gentle like this. Not like this. The gentle massage is you change the like tennis, tennis changes the input, get control there, same thing. That's all. You can try it. Patient tomorrow they come. I think a lot of ONE will come. Just make them sit down. Then ask the patient, do you do it, and ask him to strength, and you'll see by yourself. I also never believed this. When I did it myself, when I have knee pain, I did it, and asked for the patient, I did it. At least 2-3 hours, you're okay, fine, but any pain. That's what your diclofenac will do. But that will damage your kidney, isn't it? It doesn't.
Okay, so far, no more questions, sir. Anything you want to say, Sanjay sir?
I want to say that suppose there is a chance that you did not get a successful result. Can you combine some drugs also? Medicine?
Yes, of course. The drug I use if the patient cannot sleep mostly.
Yeah.
And of course, therapy. The basic therapy for youngsters, I will say, if they're still here, in the knee pain, if there is stiffness and pain, use heat. If there is pain and swelling, use ice. Be very clear about it. Okay. In the knee, there is stiffness and pain, use heat therapy. If it is then swelling and pain, use cold therapy. Some other therapy, they come and show this prescription after what is written. How can you get heat when there is a fusion? Okay. So they should be good. So about drugs, of course, 100% I use drugs when they are going for a marriage or they are going for a long day for them. And I tell them, if you are a long day, take it and go. But don't come back and take. You take a tablet before you get pain, go. Okay, I give them medication. But most of them come with a lot of medications. They themselves have already taken a lot of medications.
Okay, thank you, sir. We are coming to.
Please try them, Dr. Sahu, and come back.
Yes.
So next week, if it is there, I will show only videos of some manipulation, mobilization, which I do.
Okay, sir. I will take care of that.
Thank you. I want the feedback from your participants. Okay.
Yeah.
Okay.
Let them try it and tell them. Okay.
Okay, thank you.
Okay,
thank you, Dr. FEROZ. Thank you very much.
Thank you very much, sir. As a customer, I must thank everyone whoever has joined this webinar, and I must thank all the office bearers of IAPMR and APMRO, and the director of NITAR who is supporting constantly for this organizing this webinar. I must thank the chairperson and the president of APMRO, Dr. Sanjay Das, and also thanks to Dr. FEROZ Khan for his interest on teaching students and exploring a new horizon where we have very little experience on that. And I must thank the PR team who is helping us for propagating this webinar in all platforms. And thank you very much. Thank you everybody for joining this webinar. Thank you. Good night.
Thank you, everybody. Thank you.
Thank you. Good night.
Good night.